Okay, it's time to talk about anesthesia. Let's go ahead and get started. This is a pretty long chapter. There is a lot of good pearls in it, so definitely some stuff to take away from here. All right, so today we'll talk about some of the inhalation agents, some of the IV agents, some of the equipment used, patient monitoring, what anesthesia is looking for in their preoperative evaluation, as well as some of the techniques that they use and choose to use depending on the patient population, and some pain and pain management. So when we're talking about inhalation agents, we're talking about historically ether and nitrous oxide and chloroform. There was a lot of side effects and drawbacks to these agents. Ether, this is slow induction. They had delayed emergence. You had to use a lot of it to get the paralytic effect that you were looking for. Nitrous oxide was a rapid induction and rapid emergence, so that was good. But it also had some pretty significant side effects. And then chloroform, this is obviously what you see when someone holds a rag, they douse it with some liquid, and they sneak up behind you, and they put that over their face, and you go down. That's chloroform, traditionally. But this also has some problems. It can cause some hepatic toxicity, and it can even cause some occasional fatal cardiac arrhythmias. So nitrous oxide, this was again one that was used traditionally. It's still used in somewhat, but used in combination with other stuff. There's minimal influence on the respiration and hemodynamics of the patient, which is why it makes it such an attractive agent. Again, like I mentioned, it's often used in combo with some of the more potent volatile agents, which allows you to use lower dosage of the nitrous oxide. It is 30 times more soluble than nitrogen, and it diffuses into closed spaces. This is a common test question. They say, you get a patient with a small bowel obstruction, which of these agents would you not want to use? Or has a pneumothorax, which one of these would you not want to use? The answer is nitrous oxide because it can diffuse into these closed spaces where they're like small bowel obstruction or a pneumothorax, and it can cause worsening of those. There is a higher incidence of post-op nausea and vomiting with 70% nitrous oxides when that is used independently for induction purposes. When you're talking about isoflurane, again, this is one of the newer agents. It was approved in 1979, so relatively new. It was cheap, and thus it's still used in a lot of modern operating rooms. Compared to halothane, it has less reduction in cardiac output. There's minimal metabolism of it, so it's not getting broken down into any toxic metabolites. There's less sensitization of the arrhythmogenic effects of the catecholamines. However, it can cause some tachycardia, and you do need to monitor closely, and it has an extremely pungent odor, which doesn't make it a very appealing agent to use as an induction agent, because the patient's still awake when you're inducing them, and therefore if they smell like, shitty gas coming into their mask, they're not going to be too happy with you. Some of the newer ones, isoflurane being kind of the older of the newer ones. Some of the other ones, you'll hear the anesthesiast talking about, use DES or SIVO. That's desflurane and sevoflurane. So the most important characteristics about these is that the blood gas solubility coefficient. So this measures the uptake of the drug by the blood. So the less soluble, so the lower the efficient number will be. So the less soluble it is, the more rapidly you will have induction and emergence from anesthesia. And then you have your minimal alveolar concentration. So this is the concentration of agent that's required to prevent movement in response to skin stimulus in 50% of the population. So the higher the minimal alveolar concentration, the less potent. Obviously, if you need more of it to achieve that, then it's not very potent. And then you obviously have pungency. So low pungency, not only is it better in terms of just overall appealing sense, but it's less airway irritation when you deliver it at commonly used concentrations. So those are some of the things that anesthesia is taking into account when they're choosing what inhalation agent they're going to use. Does the patient have underlying medical issues that would preclude them from using one or the other? That's not something that we think about too often, nor should we necessarily have to, as this is a complete residency in of itself, and they go through a lot of training for this. But it's good to have an overall kind of broad brushstroke understanding of what's going on here. So Sevoflurane, so relatively low solubility, which means it's got rapid induction and emergence. It has a pleasant odor. I'm not entirely sure what it smells like, but apparently it's deemed pleasant by the authors of this chapter. It has reduced airway resistance, so more than halothane or isoflurane. There's minimal cardiovascular effects. It does have a considerable metabolic breakdown into fluoride ion concentrations, which in humans hasn't been shown to do anything, but in animal experiments, I guess it breaks down to some metabolite called compound A, which can be nephrotoxic in animal experiments, but it's still being used here on humans. Desflurane, so this is the most volatile and the least potent of the volatile anesthetics. It requires a specialized administration via heated vaporizers, so it's not used quite as often in some ORs as it requires this special equipment, which can be costly. It has a very pungent odor, so again, not something you're going to want to use by itself necessarily as an induction agent, and it can be associated with some tachycardia and hypertension if you increase the concentration too rapidly. If we're talking about IV agents, this is important to know. A lot of our bariatric patients, or all of our bariatric patients, when they're having surgery, are going under total IV anesthesia. So the original agent that was used for IV anesthesia was thiopental. It was part of a multi-drug combo to produce this. The benefits are that it's rapid, pleasant, and safe for most patients. The most common agents used are propofol, ketamine, methotrexate, etomidate, and Versed. This is something you definitely want to know about. We use these agents when we're doing conscious sedation. We use these agents when we're trying to do, rapid sequence intubation and some pain control issues with ketamine maybe on the floor as well. But so yeah, this is definitely something you want to know. Keep in mind and have a pretty good understanding about these medications. So propofol. Obviously, we're using propofol most often for either conscious sedation or for sedation patients who are having continuous infusions on the floor. When you're talking about it for anesthesia purposes, when you're talking about it for IV induction, the things that we like about it are that it's short-acting, it doesn't produce any post-operative or post-anesthesia nausea, so it's when they emerge from the anesthesia, they don't have any nausea when it's just used for propofol. You can use it as a continuous infusion, like I mentioned, during bariatric surgery. But some of the limitations, you always say, you'll hear anesthesia, hey, you might feel a burning sensation when this goes in. That's completely normal. And you can see some hypotension. So obviously one thing to look for when you're on the floors, you got a patient in the ICU and they're on pressors and their propofol's at 50. Keep that in mind. That could probably be contributing to it. And it causes excellent bronchodilation, so this is good. So along with ketamine, you get a blockade of the vagus nerve mediated cholinergic bronchoconstriction, causing bronchodilation, and that's a benefit when you're wanting to ventilate someone and have good respirations. So ketamine, so this is a good drug. I know Leslie knows a lot about this, so you can pick her brain for some more information. But it is something that we probably don't use very often. I know Jamie had a lot of experience with this as well in South Carolina, and I think we're trying to get a little bit more familiar with it and maybe use it more on the floor. When you're talking about it as a IV agent for induction and anesthesia, you're looking to produce this dissociative state, and it also does provide some somatic analgesia, so they'll get some pain relief from it as well. It can increase their blood pressure and their heart rate, and it decreases the bronchomotor tone. It causes the least amount of ventilator depression and loss of airway reflexes, which is why it's such a good agent for like conscious sedation if you're trying to, either take care of an unruly trauma patient or someone that you're trying to, do an IND on or something like that. It's a great one because it doesn't cause that respiratory depression. It does cause some increased airway secretions, so they have glycopyrrolate that they have available or give with it oftentimes in the OR. It does not provide any muscle relaxation or control of visceral pain, and the only IV agent that can cause increased cerebral blood flow. So, they'll say you don't want to use it necessarily with head injuries. And then you want to give it with a benzo to prevent some of that emergence delirium. All right, etomidate. This is another medication that we use frequently for rapid sequence intubation. It can produce minimal hemodynamic changes. You may also experience some burning pain on injection. You may hear of someone talking about the potential for adrenal suppression. This is not very common, but it is something you need to be aware of. And it's usually only seen when people are given this as a prolonged infusion, not as, a bolus for RSI. And then there's thiopental. This is not one that I'm familiar with. This is the oldest IV induction agent. It was very rapid and pleasant, but it did have some pretty significant side effects that caused vasodilatation that could cause cardiac depression and severe hypotension. So clearly not an agent that you would want to use right now. And then Versed. Obviously, midazolam, it's a benzodiazepine. It's very, very, very commonly used for a variety of situations. It doesn't have any, or has very minimal cardiovascular side effects. It's a shorter duration of action compared to like Valium. So that's why it's going to be good for more of an RSI or for conscious sedation. And it has an acceptably rapid onset of action. And it can produce some pretty profound amnesia for painful or anxiety producing, so like colonoscopy or maybe an MRI, and they need some more long-term sedation. So opioids are used for more than just pain control. You can have actually a variety of uses. They're given as part of this combo multimodal anesthetic regimen. These produce the analgesic aspect of anesthesia with the minimal cardiac depression. They do cause some ventilatory depression and some inconsistent hypnosis or amnesia. That's why it's used in combination with things. They will reduce the mean alveolar concentration of the potent inhalation agents. So again, by using these multifaceted anesthetic regimens, you can decrease the dosages that you're giving people of certain medications, which can decrease the amount or the potential for toxicity or side effects. It can blunt some of the hypertension and tachycardia associated with intubation and skin incision and other surgical pain, and the analgesia will extend beyond the time they wake up from anesthesia. Some examples are morphine, hydromorphone, or Dilaudid, meperidine. These are cheap. They're intermediate acting agents. They're used all the time. And then anesthesia's, go-to is what we see most often is going to be fentanyl. It's because it's much, much more stronger. It's 100 to 150 times more potent than morphine, and it's commonly used for the maintenance of anesthesia. It's quick on and it's quick off too. So neuromuscular blockade, you'll often hear, on our side of the drapes, hey doc, the patient's pushing on me. So they're not relaxed enough. They're making it difficult. Their pneumo's going away. They're bucking, whatever it is. You need them to be relaxed. So what do we use? There's two categories, depolarizing and non-depolarizing. There's only one depolarizing agent, succinylcholine. Again, something we use quickly for rapid sequence intubation. It has extremely fast, rapid onset. It's got a very short duration of action, which makes it very popular. Its mechanism of action, so it has an agonistic effect at the cholinergic receptors of the neuromuscular junction. Some of the serious hazards that you'll hear about are hyperkalemia, malignant hyperthermia. So if you're going to use this for RSI, you're going to want to make sure the patient isn't like a burn patient, or they had a head injury, or they have a family history of malignant hyperthermia, or a crush injury, things that would cause hyperkalemia, maybe even a diabetic patient who's on chronic kidney disease, renal failure. If you have time and the ability to check potassium, I know I almost got burned once, and believe it or not, Maury Witkoff was the person who caught that the patient had hyperkalemia before I did a intubation using succinylcholine. So we switched it up and used other agents at that time. So it's metabolized by plasma pseudocholinesterases. So the other class of neuromuscular blockades are going to be your non-depolarizing agents. These are chosen largely based on how they're excreted. So you've got your vecuronium, rocuronium, pancuronium, and cisatracurium. Pan and vec, so pancuronium and vecuronium, these are both eliminated renally. So if you've got someone with kidney disease, chronic kidney disease, acute kidney injury, acute kidney failure, this is not going to be the drug of choice. Cisatracurium, so this undergoes Hoffman degradation, meaning it's broken down in the plasma, so it's not going to be cleared renally or hepatically. This is the one that you're going to choose. Most often than not, if you're trying to produce a long-standing neuromuscular blockade or paralysis, say for a patient in severe ARDS who requires paralysis, or a patient with increased intracerebral pressure who is having multi-organ failure, and you need to paralyze them so they don't have an increase in their ICPs. Cisatracurium is going to be your drug of choice for that. But when we're talking about anesthesia and in the operating room, how is anesthesia measuring? When you say, hey, they're pushing on, they go, no, I just gave them something. They got 0 twitches. Well, what does that mean? Well, train of force. So this is a semi-quantitative way of monitoring technique used to assess the adequacy of blockade. So if your train of force ratio is greater than 0.9, this is considered an adequate return of neuromuscular blockade. So that's at the end of the case. So they'll give a stimulus and they'll see on their thing how many twitches they get. If the fourth twitch is of the same magnitude as the first twitch, or is at least 90% of the magnitude of the first twitch, then you can say that that patient has been sufficiently reversed. And if you do need to reverse them with medical agents and the medication didn't just wear off on its own, they'll use neostigmine in the operating room along with glycopyrrolate, again because of some of those cholinergic effects where you get the airway secretions. Okay, so that's a good kind of quick, dirty introduction to some of the IV induction and anesthetic inhalation agents. When we're talking about patient equipment, I'm not going to go too involved in this. There's, obviously a lot of things up there at the head of the bed that anesthesia has that is important and has been really a huge area of technological advance in the last, 50 years as to what they're able to do and how they're able to operate on sicker patients because of better monitoring. So this was established. They've got standards for what you need to monitor and how to monitor it. The American Society of Anesthesia established standards for monitoring. These were most recently updated in 2011, as far as I could tell, so maybe a little out of date, but for the most part, this is when they were updated. So you need a qualified person at the head of the bed, so that can be an anesthesiologist, a CRNA. They need to have continuous assessment of the ventilation, the oxygen, the circulation, and the temp. So the monitor, they need to have a monitor that says if the oxygen goes low, that an alarm sounds. They need continuous pulse oximetry. They need a quantitative end-tidal CO2 measurement. And they need a device that says if the system becomes disconnected for whatever reason, then an audible signal goes off. And then they need continuous EKG monitoring. And then depending on the situation, a bare minimum of every 5 minutes of blood pressure and heart rate monitoring. And they need a way to evaluate temperature. They may have a Foley for temperature. They may have the forehead temp monitor. There's a variety of ways to do that. So when we're talking about preoperative evaluation, this is actually something that's pretty important. The anesthesiologists take this real seriously because it can key them off into something in their history or current medical status that may change what medicines they use or what lines they need, and it can be important. So again, there's standards for pre-anesthetic care in which the doctor is required to evaluate the patient, derive a plan, and discuss that plan with the patient. This is the anesthesiologist. So routine testing has not been shown to be of benefit. For the most part, for elective cases, this is just adding cost and has little impact on the patient care. Focus history and physical, and if they have labs within the last 6 months for most elective non-cardiac cases, that'll suffice. Pregnancy tests, pretty controversial. There's really no clear evidence that demonstrates an association of anesthetic drugs being related to fetal abnormalities or anomalies. So, do we get them? Yes. Is it necessary? Probably not, unless the surgery you're going to be doing may impact the fetus itself. So airway exam. This is obviously what anesthesia is primarily focused on, or at least one of the key aspects, because this is kind of their area of expertise. So they want to know any characteristics that may hinder mass ventilation or intubation. So those include mouth opening, the mobility of the neck. Have they had previous neck surgery, anterior cervical disc, fusion or whatever? Thyromental distance, the size of the tongue in relation to the oral cavity. Do they have beards? I know that can make it much more difficult to bag them. And then they want to know the Mallampati classification. So this is performed with the patient in the sitting with the head in a neutral position with the mouth wide open as far as possible and the tongue protruded maximally. So unfortunately, I guess the figures didn't upload. But so there's 4 classes of this. Class 1 is going to be where the pharyngeal structures are visible. If you can visualize the soft palate, the fauces, the uvula, the anterior and posterior pillars, that'll be class 1. Class 2 is going to be visualization of the soft palate, the fauces, and just the uvula. Class 3 is visualization of the soft palate and the base of the uvula. Class 4 is visualization of just the soft palate, and you can't see the uvula at all. Or, excuse me, the soft palate will not be visible at all either. So when you're talking about cardiovascular disease, I think we've had a couple of M&Ms where we discussed this, but the American Heart Association has some guidelines for perioperative cardiovascular eval and management. Again, this is a patient's undergoing non-cardiac surgery. So it's going to focus on their history of cardiovascular disease, their exercise tolerance, and the type of surgery that they're going to be undergoing. The term METs, or metabolic equivalence, is going to be thrown out there pretty often. This more or less just determines their functional status. 1 MET is equal to the resting or basal oxygen consumption of a 40-year-old 70-kilogram man. If you can perform anything more than 4, you're okay for surgery. If you're less than 4, this may be an indication for some stress testing. But what patients are going to benefit from cardiac testing? There is a table and a flow chart in the chapter 14.2 that kind of goes over this. It's a stepwise approach to the patients who are undergoing non-cardiac surgery. More or less, is it an emergency? You kind of need to risk stratify them, and then proceed to surgery. If it's not an emergency, do they have acute coronary syndrome? Okay, then obviously they're going to need something going on with that. If they don't, then you need to estimate their cardiac risk, their combined clinical and surgical risk. If they're low risk, they may not need any further testing. If they've got an elevated risk, but they're able to complete more than 4 METs, but less than 10, you probably don't need any testing. If they're able to complete less than 4 METs, and they have either a poor or unknown functional capacity, then you may want to do further testing. This could be stress testing if you have time. If you need to go to surgery, then you may have to just go to surgery and then do some non-invasive testing as it sees fit. So what are some of the tests that they get to evaluate the cardiovascular disease in the preoperative setting? So 12-lead EKG. This is a reasonable test for those with known coronary artery disease or structural heart disease. If they're just undergoing a low-risk surgery, benign lesion on their arm removal, maybe an umbilical hernia potentially, they may be able to get through this without any 12-lead EKG necessary. When do we assess someone's left ventricular function? With an echo. If they have dyspnea of unknown origin, heart failure with worsening dyspnea, those patients are under higher risk for having some underlying left ventricular dysfunction or pulmonary hypertension, and therefore they should be probably getting an echo prior to surgery. Otherwise, it's not recommended for any kind of routine evaluation. Stress testing, either with a cardiopulmonary exercise test or a non-invasive stress test. There's really no use for this, again, unless someone's having unstable angina or history of pretty high-risk coronary disease. And then angios, there's really no angiography recommendations unless they're having a STEMI. All right, now this is important as well. A lot of this is important, but this actually, I think some of the chiefs from a couple years ago mentioned that they got this on their board exams. I think it was I don't remember if it was the oral boards or if it was the written boards, but they were asking them about when in the perioperative or preoperative setting to get and hold antiplatelet or anticoagulation medications. So who needs a stent or antiplatelet medication? So if a patient has undergone an angio only without any stent placement, then you can delay their surgery for a minimum of 14 days. If they've had an angioplasty with a bare metal stent, then you need to delay the surgery for a minimum of 30 days. If they've had an angioplasty with a drug-eluting stent, current evidence is indicating that the risk of thrombosis is stabilized after 6 months. However, if they do undergo a surgery in this period, in this window before the 6 months, the rethrombosis is usually not life-threatening. We did have a patient with MI who had a drug-eluting stent placed. He had an MI in the postoperative period. It was done, within less than 6 months. Certainly, I think it was less than a month since it was placed. And we did the surgery on aspirin and Plavix. They tried to do a angio and heart cath with when he had reproduction of his STEMI, and they couldn't cross a wire across the thrombosis. But it wasn't life-threatening. He was managed on a heparin drip. He was already kept on his aspirin and Plavix. He ended up doing fine. But again, there is a real risk there, and I've seen it firsthand. So definitely something to keep in mind. If you can delay the surgery until that 6-month window period is up, that's probably going to be your best case scenario. Beta blockers. So these have been shown to reduce perioperative myocardial ischemia. They may actually reduce the risk of an MI and cardiovascular death in high-risk patients. The current recommendations are to continue beta blockers in patients who are on long-term beta blocker therapy. The initiation to those beta blockers in those that are beta blocker naive is not recommended. When you're talking about some of the overall recommendations for the perioperative medical management of those with on beta blocker therapy or antiplatelet drugs, and the timing of those if they've had a percutaneous coronary intervention, this is a good box that kind of breaks that down. If the patient's on Plavix, the best thing to do is wait 4 to 6 weeks if they've had a bare metal stent, and again over 6 months if they've had a drug-eluting stent. If they are on, ACE inhibitors, you want to continue the ACE inhibitors in the perioperative period. If they have acute kidney injury and you want to hold them, that's fine. You can restart them postoperatively. And like I mentioned, beta blocker patients who are beta blocker naive, there's really been no benefit seen in patients to start them on a beta blocker in the perioperative period without any other risk factors. Endocarditis. So I think in the past, you've heard, they have high-risk procedures being dental procedures, those involving the airway, and therefore they have a valve who they need prophylactic endocarditis antibiotic prevention. So these guidelines changed in 2007 regarding the prophylaxis. It's no longer recommended based solely on an increased lifetime risk of developing this, and it's reserved really for only those who are at the highest risk. So dental and respiratory tract procedures, if they have a valve and they're at high risk and they're undergoing one of these, to prevent endocarditis, you can prophylax them with amoxicillin. All right, pulmonary disease. So, who's going to get a chest x-ray? Who's going to get an ABG? Who's going to get PFTs? Not everyone. It's going to be based on your focus history or the anesthesiologist's focus history. The goal is to detect and treat any reversible pulmonary pathology. You want to optimize their medical management and then allow for post-op vent planning if you think they're going to stay on the vent. Some of the major predictive factors are going to be a surgery greater than 3 hours, any emergency surgery, or general anesthesia. High-risk procedures, anything involving obviously the thoracic cage and lungs, the abdominal surgeries, neurosurgeries, head and neck, and vascular. So, that's pretty much all surgeries. They should probably throw ortho in there as well. So what do they do for renal and hepatic disease for preoperative evaluation? So chronic kidney disease can cause a variety of perioperative issues. It can throw off your acid-base status. It can cause significant electrolyte problems to the extent where multiple cases will be either canceled or delayed if the patient's hyperkalemic, especially if you're doing AV fistulas and the patient's coming in, they have a need for dialysis, they miss dialysis, now they come in, their K is 7, that patient will probably be canceled. The recommendation is if they're getting, either HD via temporary dialysis catheter or via a fistula, that they get spun within 18 to 24 hours prior to surgery. This is in an attempt to help avoid some of the fluid shifts that you may see. Chronic liver disease, so patients with hypoalbuminemia, this can cause acute and long-term effects with anesthetics. Some of the binding of these to albumin in the bloodstream and therefore can change the potency of the medication. If you have cirrhosis and you're a child's Pew, A, B, or C, or you have a MELD score that's greater than a certain amount, these are associated with significant operative risk, and you can cause some serious coagulopathy issues depending on how severe your cirrhosis is, or your underlying chronic liver disease from whatever reason it may be, and that needs to be addressed preoperatively as well. So when you're looking at someone's nutrition, endocrinology, and metabolism, they want to know about diabetes because there's a very strong correlation between mortality and tightly controlled blood glucose in the critically ill surgical patients. Our goal for patients in the postoperative period is tight blood glucose control under 180, but obviously greater than 90. There have been studies that showed that too tight of control actually led to episodes of hypoglycemia and the sequelae of that. So, parameters now up to 180 are acceptable. You can use insulin pumps. So if the patient has an insulin pump, it should be continued at their sleep basal rate. If they show up the morning of, you want to reduce the dose of their intermediate or long-acting insulins and hold any short-acting insulins. If the patient is MPO, you need to provide glucose in their IV fluids and monitor their blood sugars daily. And if they are type 2 diabetics, you usually hold their oral medicines at the time of surgery and any non-insulin injectables the day of surgery as well. Metformin, we usually hold this in the postoperative period at least for 48 hours, especially if they've had any contrast imaging, as this can be associated with a slight increased risk of drug-induced lactic acidosis. All right, so the American Society of Anesthesiology, you're doing their time out in the OR, and they say he's a class 3E or 4E or class 2 or whatever. What does that mean? So this is a way to assess their overall physical status. They have a classification system of 1 through 5. We shouldn't really be operating on 5s, and if we are, they're likely going to die, as you can see there. But it's a big scale. 1 is no organic, physiologic, or biochemical or psychiatric disturbances. 2 is mild systemic disease, hypertension, but it's well controlled. 3 is severe systemic disease, and this could be a previous history of a heart attack or poorly controlled or uncontrolled high blood pressure. 4 is going to be those who have a constant threat to life. This could be unstable angina, congestive heart failure, and if you hear them throw an E behind that, that just means it's an emergency. Okay, so this is the Mallampati score that I was showing you earlier. So this is the most critical skill of the anesthesiologist, is their ability to manage the airway. You got a bad airway on the floor, you got a bad airway in, the OR or the ED, anesthesia is around, they're in-house. These people can help you out of a very tough situation. You're going to want to call them if you need to. So there's a variety of techniques that can be applied. Difficult direct laryngoscopy occurs in about 1.5% to 8% of general anesthetics. Failed intubation will occur in about 1/3 of 1% of general anesthetics. And there are a variety of guidelines for managing a difficult airway. So let's talk about, we can briefly, touch on some of the different techniques that they use. So, a difficult airway, say you got a patient with a super large thyroid causing some tracheal deviation. You may not be able to see their cords. They may be deviated to the point where you can't get any pressure. You can't see it. You can do fiber optic. You can do direct. You can do awake intubations. You want to make sure that if they do have, potential compression of their airway, that you don't paralyze the patient first, so that they relax all the way. Now it compresses, closes off their airway, and you can't breathe on their own. That person's going to end up needing a crike. So they have a variety of techniques, and someone definitely to have around if you have a difficult airway. So types of anesthesia. So there's regional anesthesia. This is a good option and provides excellent post-op pain management in selected patients. These are going to be your spinal, your epidural, and your peripheral nerve blocks. I think we're trying to utilize these more and more in the correct patient populations. These have been hugely beneficial. So what drugs are we going to use for these regional anesthesia? So these are going to be your amides and your esters. So these are dose dependent. They cause a blockade of your sodium current in your nerve fibers. There's a variety of pKa's, which refers to the pH at which half the drug exists in the basic uncharged form and half in its cationic form. So whatever that means, the lower the pKa, the faster the onset. Most of these have a high pKa, and it renders them largely ineffective in acidic environments. So if taking your local and injecting it into the acidic environment of an abscess cavity will not provide any pain relief, and the patient will not like you if that's the only place that you injected them. So what are the local anesthetics? So when we're using these for a regional block, toxicity depends on the site of injection and the speed at which it's absorbed. You want to make sure you're drawing back before you're injecting so you don't inadvertently inject it into the bloodstream. If you do have some toxicity, the kind of textbook signs or answer is going to be, perioral numbness and tingling. They may have a metallic taste. They may get lightheaded, tinnitus. They may have some visual disturbances, and in the severe case, some cardiovascular collapse. You can add epinephrine to your local anesthetics. What this does is it slows down the absorption rate. It also causes some vasoconstriction, so it can decrease some blood loss. It decreases the likelihood of a toxic response secondary to that rapid absorption. And some studies have shown that lipid emulsion infusion can be a way of rescuing some subjects from a severe local anesthetic toxicity. I don't know much about this. I'm not sure I've ever seen it, and it's not something that we would do, but it's good to have in the back of your mind. So this is just a table that shows you some of the important characteristics of the local anesthetics, kind of the duration of action. We use 0.5% bupivacaine or Marcaine, which is a combination, or if you're using lidocaine with epi. This tells you if it's an amide or an ester. Know that the amides all have 2 I's and the esters don't. That's how I remember which ones are which. And then when you're looking at your speed of onset and your duration of action. So, bupivacaine is going to last a lot longer than lidocaine, and then those are your max dose. The max dose does go up for if you have epi with it. Okay, so spinal anesthesia. So this has a lot of applications. It can be used in urologic procedures, lower abdominal procedures, perineal procedures, and then lower extremities. So what they do is you're injecting the local into the subarachnoid space. This is going to provide excellent sensory and motor block below the level of that. It's got a variable speed of onset, and the duration kind of depends on which agent you're using, the volume of the dose that you're using, what position the patient is in, are you using any vasoconstrictors with it, are you adding opioids to it, and then anatomic or any other physiologic factors that the patient may have. The advantage of this is that you're avoiding any manipulation of the airway. So if you need to interact with the patient during, say, the procedure, you want to know if get some feedback, this is going to be probably your choice. Intrathecal administration of opioids can also provide some high-quality post-op analgesia. What you do is you, either as a bolus or a continuous infusion via a large catheter, you can introduce these medications into the intrathecal space. It's not without complications. So hypotension, bradycardia, they can have a post-dural punctural headache, they can have transient neuropathies, urinary retention, and an epidural hematoma. So there are patients that the anesthesia will say, nope, not going to do it. So anyone who's septic, has bacteremia, they have an infection at the site of injection, they're hypovolemic, they're coagulopathic, or they're on therapeutic anticoagulation, or they have an increased intracranial pressure, or the patient strictly just refuses. Okay, then you have epidurals. So, I think everyone knows the epidural from patients who are giving birth. This is a neuraxial block. There's a wide variety of abdominal, thoracic, and lower extremity procedures that it's good for. In terms of its ability to provide a good block, I know my wife had an epidural when she gave birth, and she was pretty much numb from the waist down, and it lasted quite some time and provided a significant amount of relief of discomfort. So she had a catheter that was in there, and they were able to bolus and change the dose and titrate the infusion as such. You can do this again with or without opiates. It's injected into the lumbar or the thoracic epidural space, again via catheter, like I mentioned. It can decrease blood loss. It can lower the potential of DVTs during total joint cases. Post-op analgesia for thoracic surgery. It can provide pretty good pain control for that. There's less sedation associated when you use these, and better pulmonary function than parenteral opiates. There's always risks when you do this procedure. Some of those include spinal hematoma. This can be associated if the patient is on prophylactic low molecular weight heparin. So generally you don't want to place this within 24 hours of low molecular weight heparin being administered, and you shouldn't start low molecular weight heparin less than 6 hours after one gets placed. Okay, peripheral nerve blocks. So this is again, more targeted. You're blocking the peripheral brachial plexus or the lumbar plexus or specific peripheral nerves. These are good for procedures that involve the upper and lower extremities. Almost all of the uh, AV fistulas that you'll do can be done under a brachial plexus block, at least over at OSU. It does require a cooperative patient. You need a skilled anesthesiologist along with a surgeon who's accustomed to working on awake patients. Again, that constant interaction. You need to be able to convert from the peripheral nerve block to a general sedation, uh, general anesthesia if necessary. You can have local toxicity, you can have some nerve injury, and then you can have inadvertent IV injection. And then there's conscious sedation. So this is something we do on the floor. This is when a non-anesthesia personnel administers sedation for surgical procedures. You need continuous monitoring and a trained assistant, along with immediate availability of airway and resuscitation equipment. So there are specific protocols that we have to follow in the hospital as residents and as attendings if we're going to perform conscious sedation. There are power plans, and then pharmacy needs to be there. You need a rapid response nurse, I believe, if you're doing it on the floor. You can have ED nurses if you're doing it in the ED, and then you need to, have the correct paperwork filled out and documented during the procedure. All right, so post-anesthesia, what are some of the problems that occur? So post-op nausea and vomiting. It's probably the most annoying problem for not just patients, but for personnel in the PACU. A wide variety of agents that both cause this and that treat this. The use of propofol, like I mentioned earlier, can decrease the post-operative nausea and vomiting. The mechanism behind this, behind nausea and vomiting, so the brainstem of the area that control the nausea vomiting reflexes is the chemotactic trigger zone. This contains receptors for dopamine, acetylcholine, histamine, and serotonin. If you combine all of these, you may get nausea and vomiting. And again, when we're trying to relax someone, whether we're using, anticholinergics or benzos or whatever, you may induce this. So by blocking all of these, you can theoretically treat post-op nausea and vomiting. So some of the medications that you'll see some of the anesthesiologists use include Haldol, which is one that's a good anti-nausea medication, Reglan, Benadryl, scopolamine, atropine, Zofran, uh, and then some steroids. Hypothermia. So there are this is a pay-for-performance issue, meaning the Centers of Medicaid and Medicare will actually ding you if you're not keeping close monitoring of this and meeting certain standards. So it can cause alterations in oxygen consumption post-operatively as a result of shivering, which can cause alterations in drug metabolism and effects on coagulation. It's part of the triad of death, obviously, hypothermia. So it's something that you definitely want to have control of. It can increase risk of surgical site infections. So you need to report and achieve perioperative normothermia, so 36 degrees Celsius, within 30 minutes of arrival to PACU. And then again, this can be done by multiple techniques. Bear huggers are actually one way to do it. Warmed IV fluids and blankets. So what are some circulatory complications you see in PACU? This is usually going to be related to hypovolemia, so insensible losses from a large open surgery that lasted a long time, blood loss, fluid shifts. They can see left ventricular dysfunction. They can have arrhythmias. Rarely will it be one of these other ones like anaphylaxis, a transfusion reaction, tamponade, PE, adrenal insufficiency, or hypoxemia. Again, something to keep in the back of your mind. Treat any arrhythmias via ACLS. Always get an EKG. If they need fluids, give them fluids. If they need inotropes, give them inotropes. You can put the patient in Trendelenburg and supplement with oxygen as needed. On the flip side of that, hypertension. This is usually due to inadequate pain or anxiety control. Again, you want to make sure that there's no underlying cause such as hypoxemia or hypercapnia, and correct that if possible. But for the most part, just adequate pain control and anesthesia and anxiety control can help to reduce that. So pain management. So obviously you're having surgery, you're going to have pain. Acute pain is different than chronic pain. Surgical pain is deemed acute pain. It should be of relatively short duration. It should resolve when the tissue heals or you withdraw that noxious stimulus, i.e. the chest tube. Um, it should last less than a month. If it's more than a month, it's going to be termed chronic pain. There are multiple mechanisms of pain. The nociception is tissue injury that leads to the complaint of pain. There's technically 4 steps. There's transduction, transmission, modulation, and perception. So you get a noxious stimulus, which converts this to an electrical signal at the free nerve endings. Then that gets sent via the certain pathways towards the central nervous system. There, the signal gets modulated in the dorsal horn of the spinal cord, and then it goes up and it reaches the cortex, and that's where it's going to give you the perception of pain. So this is a diagram depicting that, and this shows you where the drugs that we use for pain management act to help modulate or diminish that pain. So what are some of the methods that we use to treat acute pain? So opioids. So these bind receptors in the CNS. They also probably bind in the peripheral tissues. They modulate the nociceptive receptors. The mu is the most common one that we hear of, but there's a variety of different receptors. There's varying degrees of potency and different delivery routes. Some of the stronger ones are going to be your morphine, your Dilaudid, your fentanyl, and your meperidine. We don't use that one anymore because it has a breakdown product that can cause seizures. Some of the weaker opioids, your hydrocodone, your codeine, your tramadol, which tramadol is not technically an opioid, but it's similar. There is a major barrier to the treatment with these, that fear of addiction. So either on the patient's part or on the prescriber's part. But in the acute post-op pain setting, there has been nothing shown that risk factor for development of an addiction disorder by giving someone opiates in the acute post-op period. But you do need to understand certain terms: tolerance, addiction, and physical dependence, and the difference those are, and how those may play a role in someone with chronic pain and the use of chronic long-term opiates. NSAIDs, these are great drugs. They're extremely effective. You use them in combination with other analgesic medications for post-op or acute pain. Can lead to overall decreased opioid consumption overall, which can be good and help prevent maybe some of that long-term chronic opioid dependence if they do end up with long-term medications. So it's a COX inhibitor, which decreases the production of prostaglandins. Prostaglandins are the potent mediators of pain. However, they also help provide a protective coating to the stomach, so by blocking these, you may get gastric ulceration, and you may also get some renal injury with NSAIDs. There are selective COX-2 inhibitors. Celecoxib is one of them. These have less GI risk and renal compromise, and they're only available in oral formulations, so you can't give them parenterally. Ketamine, so this is an NMDA antagonist. It's a great induction agent, and it has some strong analgesic properties. It does cause some psychotropic adverse effects, so you need to give them a benzo when you're giving with ketamine, so that it produces some of that prevents some of that emergence delirium. Alpha-2 agonists. So there's a high density of these receptors in the substantia gelatinosa. That's the area of the dorsal horn where that nociceptive pathway or stimulus is being sent. Clonidine could be of some use. The doses are pretty high, and therefore it can have some pretty significant hypertensive properties, as alpha-2 is going to cause some vasoconstriction. So combo therapy, so this is really the mainstay of acute pain management or multimodal therapy. What they get in pre-op, what you're getting intra-op, what you're getting post-op. A combination of different medications can really provide the most pain control and decrease the dosages of certain medications as well. You can get synergy amongst certain agents and potentiation of the effect and reduced dosages, like I mentioned, of an individual agent. Some of these drugs that we're using in combo therapy include gabapentin. It's an anticonvulsant. It's used often for neuropathic pain, but we're using it a lot in the acute pain management. There are some guidelines out of some of the major academic institutions. I'm trying to remember which one it was. Johns Hopkins, I think, in the post-op management where they're using gabapentin and really trying to avoid narcotics at all in their post-operative gallbladder patients. Preemptive analgesia continues to be actively explored. The goal there would be obviously to inhibit or influence the analgesic process before the noxious stimulus is actually applied. So the skin incision or the chest tube placement or the intubation, whatever it may be. So chronic pain, There's a subset of patients where pain persists well after the expected healing time, despite lack of pathology to explain the pain. So this is going to be any patient who's having pain greater than a month beyond that expected of the time for recovery. They're going to use certain buzzwords. You know, the pain is burning, it's shooting, it's shock-like. And then there are specialists that are entire fellowships that can be done just to treat chronic pain. Some of the options they're going to use may include antidepressants, anticonvulsants, nerve blocks, physical therapy, and then actually psychological techniques as well. So that completes the slideshow on anesthesia. Again, it's a pretty broad topic. There's a lot of information in this chapter. I think a good overall understanding of this can help you when you are trying to either take care of patients on the floor or get a better understanding of patients and what anesthesia is going through and why they may ask for certain things or choose certain medications for your patients. Hope this was helpful. Good luck.